Welcome to the unit on the GI system agents. The function of your GI system is really to extract the nutrients from food so that they may be used to fuel the many metabolic processes in the body. Multiple steps are necessary to accomplish this, from ingesting the food to the propulsion, the digestion, the absorption, and then finally the defecation of the waste products. Remember that drugs are just a means to manipulate a currently already functioning body process. There are some of the methods listed on your slide that GI medications do manipulate the different GI functions. Remember, we don't convey a new function on the body through the use of drugs. So a quick pathophys overview. The upper GI tract consists of the mouth, the pharynx, the esophagus, and the stomach. The importance of the stomach in pharmacology is really centers around that gastric environment and its effect on oral drugs that have to pass through it in order to get to the small intestine, which, as you will recall from earlier in the semester, the small intestine is where most oral meds are absorbed. So the acid pH of the stomach can either assist in the absorption process or destroy the drug entirely. So in looking at the stomach, you can see that there are really three zones: your cardiac zone, your gastric zone, and your pyloric zone. The gastric zone is the largest and contains the majority of the gastric glands. The cells of the gastric gland are parietal cells, and these are cells that produce and secrete hydrochloric acid. As you can probably imagine, it's this gastric zone that secretes the hydrochloric acid that is the primary site of action for many of the acid-controlling drugs that we'll be talking about in this particular unit. So again, the acid pH in your stomach has a purpose. It helps to break down foods and also kills any microbes that might have been ingested. So let's start looking first at the pharmacologic treatment for peptic ulcer and GERD. So peptic ulcer disease, or PUD, is a disorder that affects about 10% of Americans at some point in their life. A peptic ulcer is a lesion or an erosion either in the stomach or the small intestinal mucosa that's usually also associated with acute inflammation. If the ulceration is in the stomach, we call it a gastric ulcer. If it is in the intestine, we call it a duodenal ulcer. It's important to treat these because complications from these include bleeding, perforation, and GI obstruction due to scarring. H. pylori is one of the risk factors for developing peptic ulcer disease, and it's actually associated with about 90% of duodenal ulcers and 80% of gastric ulcers. At this time, the most proven effective treatment is a 2-week course of treatment called triple therapy. And this involves taking 2 antibiotics to kill the H. pylori, and then either an acid suppressor or a stomach protectant. The 2-week triple therapy reduces ulcer symptoms, it kills the bacteria, and then it actually prevents ulcer reoccurrence in more than 90% of the patients who are treated in this manner. GERD is a common disorder that's characterized by heartburn and regurgitation. The primary cause is an inappropriate relaxation of the lower esophageal sphincter, which then allows the gastric contents to back up into the esophagus. Although most instances of GERD occur in patients over age 40, it can also occur in infants. GERD can either be treated with surgery or with medication, and for the majority of patients, medications are preferred. Left untreated, GERD itself can lead to complications such as esophagitis, esophageal ulcers, or strictures. Before beginning pharmacologic therapy, patients should be educated on lifestyle changes that can complement the therapy. Things such as smoking cessation, weight loss, avoiding alcohol, sleeping with the head of the bed elevated, and avoiding foods that aggravate the condition are recommended whether or not we use medications to treat the disease. So there's a wide variety of both prescription and over-the-counter drugs that are available to help suppress acid secretion. These drugs fall into three primary classes and then one, what we kind of call a miscellaneous group, because it really doesn't fit anything else. So you've got your H2 blockers, which are your H2 receptor antagonists, your proton pump inhibitors, your antacids, and then the category of miscellaneous. So starting first with the histamine or H2 blockers. So these were developed back in the 1970s, and they're used to treat mild to moderate PUD or GERD. These drugs effectively reduce both fasting and food-stimulated acid secretion, meaning that they work well for both kinds of ulcers, whether they're gastric or duodenal. The proton pump inhibitors are the newer drugs for treatment of acid-related disorders. Note that they block the enzyme, the hydrogen potassium ATPase pump. This is the enzyme that is responsible for secreting hydrochloric acid in the stomach. Do not get this confused with the sodium potassium ATPase pump that we talked about in the cardiovascular system. So PPIs reduce acid secretions to a greater extent than the H2 blockers, and they have a longer duration of action. So about 95% of the acid production can be blocked using a proton pump inhibitor, making the PPIs the most effective agent for treating acid-related disorders. So we can use PPIs for the treatment of peptic ulcer disease, the treatment of GERD, and then also for the maintenance therapy to prevent the reoccurrence of either one of those. Because proton pump is activated by food intake, the proton pump inhibitors need to be taken 30 minutes before the first meal of a day. They are dosed just once a day, which then helps with patient compliance and also is more convenient. Once the drug is taken, the proton pump inhibitor will suppress acid production for approximately 24 hours. PPIs are very well tolerated. Some common side effects might include headache, nausea, abdominal pain, or diarrhea. So just to get you up to date on some of the current research with PPIs, there is definite evidence that omeprazole is able to impact certain P450 enzymes. One interaction that we are well aware of and has been identified is that with Plavix. So if you have a patient that needs to be put on Plavix, it's really important that they don't take omeprazole because omeprazole will interfere with the Plavix absorption. The acidic environment of the stomach is known to be a natural barrier to infection that's caused by bacteria that we ingest, but I bet you didn't know that it also plays a role in the destruction of respiratory pathogens. Studies have linked all PPIs, not just omeprazole, but all of them, with the increased risk of a GI bacterial infection, in particular C. diff. The link is so strong, in fact, that there is now a black box warning in place to warn providers and patients of this possibility. There's also strong evidence to suggest a link between the use of proton pump inhibitors and an increased risk of respiratory infections, including pneumonia. So something to think about with your patients that are on these medications. In looking at antacids, they provide temporary relief from heartburn and indigestion, but because we have proton pump inhibitors and H2 blockers, these are no longer the primary drug class or the first-line agents that we reach for when we are looking to treat acid-related disorders. Antacids do act within 10 to 15 minutes. However, their duration is only for about 2 hours. So therefore, patients need to take several doses per day in order to keep their symptoms controlled. There are many over-the-counter forms, so patients can usually find an antacid that they can tolerate because they come in chewable tablets, powders, suspensions, liquids, etc. So there's a lot of variety for patients to choose from. So the major ingredients of antacids include aluminum hydroxide, magnesium hydroxide, calcium carbonate, and sodium bicarbonate. So the aluminum-based antacids are not absorbed to a great amount, so they don't cause the patient to have an elevated level of aluminum in the body. However, these acids are very well known for causing constipation. Magnesium-based antacids, on the other hand, are absorbed well and can lead to hypermagnesemia. These are also well known for causing diarrhea. The calcium-based antacids can lead to a high level of calcium in your patient, which can lead to the formation of kidney stones and even lead to renal failure at high doses. The sodium-based antacids should not be used by patients who have hypertension, heart failure, or renal disease because of the sodium that leads then to fluid retention. Also, any patient on a sodium-restricted diet should not be using these sodium-based antacids. So most medications should be given 1 to 2 hours after giving an antacid because antacids raise the stomach pH and thus affect the solubility and absorption of other medications. For example, antacids can cause premature dissolving of enteric-coated medications. Because antacids raise the pH of the stomach, antacids may fool the enteric-coated capsules to think that they are in the more alkaline intestinal environment, so they start dissolving. In looking at the two miscellaneous categories, Cytotec is a synthetic prostaglandin that stimulates the production of protective mucus and may inhibit acid production to a small extent. It's primarily used in patients who have overused NSAIDs. Cytotec has a really short half-life, and thus it has to be administered 3 to 4 times a day to be effective. It is also classified as a pregnancy category X. Carafate, on the other hand, is a cytoprotective, and it's a drug that's used up to 8 weeks, so it's more of a short-term drug for most patients to prevent or treat an existing ulcer. Carafate is given orally, and how it works is it forms a protective barrier over the surface of the ulcer. It has to be given 30 minutes before each meal and at bedtime, so it too needs to be given 4 times a day. Other medications must either be given an hour before or 2 hours after the Carafate is administered. Keep in mind that when we use medications to suppress the GI acid, there are certain nutrients and drugs that need an acidic environment in order to be absorbed. Long-term acid suppression can lead to a deficiency in your patient in folic acid, in iron, and also vitamin B12. So patient teaching really circulates around those items listed on your slide. The biggest thing for patients is really to take a look at dietary changes that they need to make to avoid aggravating their condition. So, and for most people that tends to be individual. We could say that, everybody across the board can't tolerate spicy food, but some people's tolerance is a little bit higher than others. So it really comes down to patients keeping track of what they eat and what makes their symptoms worse, and then eliminating those particular foods that make their symptoms worse. Moving on to the agents to treat constipation, diarrhea, and nausea. So bowel disorders such as these are among some of the most common GI complaints for which patients seek medical attention. In addition, these are also the most common side effects of many other drugs that may be administered to the patient. So constipation in itself is not a disease, but rather it's a symptom of an underlying disorder or condition. Constipation occurs more frequently in the older population because fecal transit time slows down as we age. The older population also exercises less, has a diminished food and fluid intake, and they are also prescribed drugs that cause constipation at a higher rate than do younger adults. Occasional constipation is self-limiting, and it may not require drug therapy. Lifestyle modifications that increase dietary fiber, increase fluids, and increase physical activity should be considered whether or not drug therapy is indicated. So laxatives are those drugs that promote evacuation of the bowel. The term cathartic is used for those agents that create an accelerated, stronger, and more complete emptying of the bowel. The cathartics are used as bowel preps prior to procedures such as colonoscopy when the physician needs to be able to see the GI mucosa. So laxatives can be given either to prevent constipation or to treat constipation. Some examples of when prevention might be considered includes after an MI, when we don't want patients to strain to pass a bowel movement, when patients are immobile, whether temporarily or permanently, and any patients receiving drug therapy that is known to cause constipation, for example, using narcotics for post-surgical pain. The choice of what particular agent is prescribed really depends on the reason for the use, whether it's preventative or treatment, the onset of action that is desired, whether we want the medication to work quickly or slowly, and also for how complete we need the evacuation to be. So as a nurse, it's important that you obtain a thorough history of the patient's presenting symptoms, what their typical elimination pattern is, and any allergies they may have. Then you'll perform a complete abdominal assessment and also consider fluid and electrolyte balance before initiating therapy. It's really important that patients not take or start taking laxatives if they are experiencing nausea, vomiting, and or abdominal pain. We need to find out what's causing those symptoms first before we initiate any laxatives. So again, a healthy, high-fiber diet and increased fluid intake and activity really should be encouraged as an alternative to laxative use. Long-term use of laxatives can result in decreased bowel tone and also may lead to dependency on the product. So now, looking at treatment for diarrhea. So diarrhea is an abnormal increase in the frequency and fluidity of the bowel movements. Like constipation, occasional diarrhea is usually self-limiting and does not warrant drug therapy. Prolonged diarrhea, however, may lead to fluid, acid-base, or electrolyte imbalances. Some examples of the disease processes that can lead to diarrhea include viral and bacterial infections, and then some of the inflammation processes that are related to irritable bowel syndrome, ulcerative colitis, or Crohn's disease. Treatment really is directed at decreasing the amount and the frequency of the stools, and then by doing so, preventing weight loss, fluid electrolyte imbalances, pain, etc. So the absorbents include your prototype bismuth subsalicylate, otherwise known as Pepto-Bismol. It is an over-the-counter drug, and doses are taken every 30 to 60 minutes, up to 4 doses, to control the diarrhea. It's really important for patients to read labels. The original formula of Pepto-Bismol contains the subsalicylate, which is an aspirin-based product. In other words, the original formulation should be used with caution with those patients who are already on aspirin therapy. If they're allergic to aspirin, they should not take it. And also because of Reye syndrome, the original formulation of Pepto-Bismol should not be used in children and teens with chickenpox or flu-like illness. There is another formulation of Pepto-Bismol that does not have the subsalicylate. Instead, it is a calcium carbonate-based product. This is the one that is recommended for children and anyone who cannot take aspirin. So again, really important that patients know how to read labels. Opioids are also very effective drugs for controlling severe diarrhea. These dramatically slow peristalsis in the colon. Your prototype is Lomotil. Side effects include central nervous system depression, drowsiness, etc., typically what you would see with opioid medications. Lomotil is actually a combination drug of diphenoxylate and atropine. The diphenoxylate is the weak opioid component, and it is not strong enough or it's not effective for pain relief, but it can be habit forming because it's still an opioid if it's taken in high dosages. So to counter that risk, the manufacturers added in atropine, as you recall, that's an anticholinergic, to the formulation. So as you recall, anticholinergics can cause constipation, so they also help with slowing down the GI tract. But atropine itself also produces severe nausea and weakness if the standard dose of Lomotil is exceeded. So therefore, the atropine that's been added to the diphenoxylate will discourage the abuse of that medication. Another class to be aware of is the use of intestinal flora modifiers, in particular lactobacillus. So this is a normal bowel flora that is often removed or destroyed by antibiotics, and it's easily found in yogurt. That is why we often encourage patients on long-term antibiotic therapy to eat yogurt. But it has to be yogurt with active cultures. So, side effects of the different medications are listed on your slide. You should be familiar with the side effects of the opioids and the anticholinergics already from previous units. So again, when we look at the antidiarrheals, it's really important for the nurses to perform a complete bowel assessment, and then also gather history of this. Finding out how often the patient's having diarrhea, how long they've had it, the severity of it, any precipitating factors, and then observing for any blood in the stool and fever along with the diarrhea. The next topic we'll look at is treatment for nausea. So we're all familiar with nausea. It's that really unpleasant feeling of the need to vomit that is often accompanied by feeling weak, diaphoretic, dizzy, and then having that increased production of saliva. Vomiting is a defense mechanism that is used by the body to rid itself of toxic substances. Once the vomiting reflex is triggered, wave-like contractions of the stomach quickly propel the contents upward. So nausea and vomiting are caused from messages being sent from the GI tract, the brain labyrinth, and the brain cortex to the chemoreceptor trigger zone, otherwise known as the CTZ, and the vomiting center that's located in the medulla. Antiemetic drugs then target trying to stop these messages by blocking their transmission along one or more of the points in these pathways. So the handout on the class website does provide the information you need for this particular category, and it will go through the different classifications for you. So when large amounts of fluids are vomited, again, that risk of dehydration and electrolyte imbalance exists. This is especially true for infants and the elderly. Drugs from at least 6 different classes can be used to control symptoms. Selection of the agent is really determined by the underlying cause of the nausea. It's important to withhold oral fluids and foods until the nausea is subsided, or at least we have better control of it. And then once it's subsided, then slowly reintroduce oral intake with small amounts of clear oral liquids, things such as popsicles, Gatorade, tea, ice chips, and so on, and then see how your patient tolerates those, and then slowly advance the diet from there.